All right, welcome to those who've just joined us. This is the Learning Lupus webinar. We are so happy to have you here today. I am posting in the chat a link to a consent form and pre-test. So you received this through email earlier this week, but if you haven't had a chance yet, please go ahead and access the link and fill that out. Thank you. We'll get started here in just a couple minutes. All right, I'm going to go ahead and kick us off here. My name is Katie Haas, and I'm the Director of Grants and Strategic Partnerships with the National AHEC organization. The NAO, the National AHEC organization, is hosting this webinar in partnership with the American College of Rheumatology via federal funding from the Centers for Disease Control and Prevention. This project is called the Rural Health Outreach Project and is part of the Lupus Initiative. The educational partners involved and the speaker have nothing to disclose today. We thank you for joining us for this webinar. As I've already mentioned, if you haven't already, please take a couple minutes to complete the consent form and pre-test through the link in the chat. Following the webinar, we will provide you with a post-test, and so please stick around after the presentation to complete it before you leave. We will also include instructions for obtaining CME credit into the chat at the end, and you will receive an email with these instructions as well. Our presenter today will speak for about 45 or 50 minutes to get through all of the great content that we have to present to you. So we do ask that if you do have questions, please put those in the chat for us to address at the end of the presentation. So with that, I'm pleased to introduce our speaker today. Dr. Catherine Lee is a rheumatologist for Kaiser Permanente, as well as a clinical assistant professor at the University of Washington School of Medicine in Spokane, Washington. She is a board certified in integrative medicine and in internal medicine and rheumatology. She is also a fellow with the American College of Rheumatology and is a member of the Northwest Rheumatism Society. Dr. Lee is a graduate at UC Berkeley and the Ohio State University of College Medicine. She completed her residency in internal medicine at University Hospitals of Cleveland, where she also completed a rheumatology fellowship. I am pleased to introduce to you today, Dr. Catherine Lee.
Thanks so much for that lovely introduction. I'm excited to be here with you today. So I'm going to go ahead and share my screen. Said this is kind of a whirlwind kind of summary of things that are important to know about lupus and how you can identify patients that would benefit from rheumatology consultation. I'm going to, oops, hang on. Why is my, all right, there you go. So Katie already went through these things. And just a reminder, so you should have signed a consent. You should do the pre-assessment before this presentation, and you'll be getting a link to do a post-assessment after this. So the goal of these small group sessions on lupus are to kind of help build sustained connections between healthcare providers and rheumatologists in areas and communities in which patients are underserved by rheumatologists, which is a lot of areas actually. We also want to raise awareness among healthcare providers of lupus signs and symptoms and what to do if lupus is suspected, and when to elevate lupus in the differential diagnosis when you're presented with individuals in groups who are at high risk for lupus. So these are the learning objectives of the talk. After this presentation, you should be able to recognize the signs and symptoms of lupus, know when to effectively refer a suspected lupus case to a rheumatologist, know how to initiate a workup for lupus, and, oops, sorry, my slide. Oh, hang on. and also be able to have increased knowledge about about lupus epidemiology and health disparities and disease characteristics. Actually, hang on just a second, because I'm not sure how to make it so that I can see my whole screen. Oh, here, maybe I do this. No. Actually, Katie, do you know how to do it? Because I have, for some reason, I have like oh wait, actually, I think I can do it this way. Hide all the, oh, there you go. So I think I'm set now. So a lupus diagnosis can take as long as 2 or more years and include visits to 3 or more healthcare providers. Which is a long time. So as you probably know, why is the diagnosis of lupus so challenging? Well, lupus is the great masquerader. It can mimic a lot of other conditions like viral syndromes, malignancies, allergic reactions, and stress. It's sometimes associated with depression or fibromyalgia. A lot of times the symptoms that go along with lupus can be vague, including fatigue, achiness, stiffness, low-grade fever, swollen lymph nodes, rashes, and it may not always present the same way. The symptoms can develop slowly or they can come on suddenly. So unfortunately, the delay in getting diagnosed can be devastating for a person with lupus. It could lead to organ failure, a 5-fold increased risk of death. But with early diagnosis, the chances of a person with lupus living a full life with a manageable chronic disease are increased. So why is this important to know? Well, a person who's feeling sick often will seek help from a primary care physician or go to the emergency room at the onset of symptoms. So it's crucial that these providers recognize potential symptoms of lupus and make referrals to rheumatologists when appropriate. So it's the Lupus Initiative's mission to educate primary care providers about lupus so people with lupus can get the correct referral, diagnosis, and treatment that they need. So a little bit about lupus. Lupus is an inflammatory, multi-system autoimmune disease of unknown etiology with clinical manifestations that can change frequently and unexpectedly and suggestive laboratory manifestations. It can be mild, severe, or anything in between. The diversity of clinical symptoms is broad and all organ systems are vulnerable. Lupus is characterized by periods of flare and remission and can culminate in irreversible end organ damage. So just a schematic on the pathogenesis of lupus. This is very much an overview. So autoimmunity is an altered immune homeostasis that leads to autoreactivity, immunodeficiency, and malignancy. The immune dysregulation leading to autoreactivity and autoantibodies in lupus occurs in different phases and likely represents the untoward effects of environmental triggers on a genetically susceptible host. So what are the demographics of lupus in populations at highest risk? Well, in terms of the epidemiology of lupus, the prevalence is about 2 to 140 in 100,000 worldwide, but can be as high as 207 per 100,000. The incidence is about 1 to 10 in 100,000. People with lower incomes are less likely to receive recommended care, and poverty is associated with poor outcomes. Women are 9 times more likely to develop lupus than men. It affects mainly women in their reproductive years. Black, Latino, Asian, and American Indian, Alaskan Native women have the highest prevalence. Lupus affects 1 in 250 African American women in the United States, and African American women have a 3 to 6 times higher risk than white women. The risk for Latino and Asian American women is between 1.4 and 1.7 times higher than for white women. African American and Hispanic Latino women are more likely to develop lupus at a younger age and to have more severe symptoms at onset. African American and Hispanic Latino women with lupus have mortality rates at least 3 times as high as white women with lupus. And although we're focusing, and lupus predominantly affects women, I also want to mention that men can be at risk for lupus as well. They may even suffer greater effects of disease than women, so I don't want to ignore them. So this is a graph that just shows that there are disparities in lupus disease burden. Racial, ethnic minorities are more likely to develop lupus at younger ages and to have more severe symptoms at onset. There are other health disparities in lupus as well. Low-income individuals are less likely to receive recommended care. and poverty is associated with poor outcomes. This is a more graphic representation showing the disparities in lupus outcomes in terms of end-stage renal disease. And you can see African Americans have much higher rates. So let's take a look at some of the symptoms of lupus. Here are some visible or external manifestations of lupus. Remember that when you're looking at skin conditions, they may look different on diverse skin tones. So synovitis, malar rash, painless oral ulcer, Raynaud's phenomena, discoid rash, Jacquard's arthropathy, vasculitis, alopecia. Here are some lupus symptoms that can make diagnosis difficult because they can be indicators of so many conditions: achiness or headache, fatigue, brain fog, depression. Here's some internal manifestations of lupus: serositis, pericardial effusion, cerebral infarct, brain atrophy, spherocytes, glomerulonephritis. So if you look at the signs and symptoms that are associated with lupus, you can see that arthralgias are most common, but also neurologic and neuropsychiatric manifestations: fever, prolonged fatigue, arthritis, skin rashes. As I said, there's a multitude of symptoms. You don't have to have all of these symptoms to have lupus. You don't even have to have a certain number of them to have lupus. But you need to be aware of these symptoms because these are things that you're going to want to pay attention to when you're trying to make a diagnosis. But unfortunately, there is no gold standard diagnostic test for lupus. So you have to look for clues to suspect lupus. The presentation is often with arthritis and fatigue. The differential diagnosis might include rheumatoid arthritis, other connective tissue disease, other skin diseases, fibromyalgia, and others. Common lupus clues are rashes, alopecia, oral ulcers, serositis, leukopenia and lymphopenia, proteinuria or RBCs or casts in the urine. So the most common screen is for anti-nuclear antibodies, and the vast majority of women with lupus will test positive for ANA. But a positive ANA test does not mean that the person has lupus. A positive ANA can also be seen in the general population without known disease. ANA could also indicate scleroderma, Hashimoto's thyroiditis, idiopathic pulmonary fibrosis, or other chronic conditions. But what do most lupus patients have in common? Well, anti-nuclear antibodies. So these are autoantibodies against various components of the cell nucleus. They can present in many autoimmune disorders, as I mentioned, as well as in some healthy subjects. So it's a sensitive test, but not specific for lupus. And because of the low specificity, ANA usefulness increases if the pretest probability for lupus is high, meaning that if the patient has symptoms and signs that can be attributed to SLE, then a positive ANA is really helpful. And because of the high sensitivity of the ANA, a patient with a negative ANA is unlikely to have lupus even when his or her clinical presentation is suggestive of lupus. So if you suspect lupus, you can order these tests: a CBC with differential, a urinalysis and renal function panel with particular attention paid to evidence of cytopenias, or if you notice proteinuria, you can do a urine to protein creatinine ratio. ANA antibody, as I said, it's positive in the vast majority of patients with lupus, but you have to be careful about false positives. Higher titers are more likely to be clinically significant. And if the ANA is positive, you could consider ordering additional autoantibodies. Anti-double-strand DNA and or anti-Smith are more specific for lupus, but they're less sensitive. Complement studies can also be helpful because they can be low in active disease, but not always. Acute phase reactants can be elevated with lupus, but also in other causes like inflammation, such as infection. So if you look at the autoantibodies we see in lupus, as we discussed, the ANA is not very specific for lupus, but it's very sensitive. Anti-double-strand DNA and anti-Smith are very specific for lupus, but maybe not so sensitive. Double-strand DNA has an intermediate sensitivity. Smith is actually low. And you can see the breakdown for some of our other autoantibodies. So how do you determine whether to order an ANA? So if autoimmune rheumatic disease is likely, then the ANA can be really helpful for diagnosis and classification. But if an autoimmune rheumatic disease is unlikely, do not order an ANA. A positive ANA can cause anxiety, unnecessary investigations, and potential confusion for both patients and providers. So if you have a patient with nonspecific symptoms and a low probability of lupus, you need to look for other clues. So look for evidence of kidney disease. So a urinalysis or urine protein to creatinine ratio. Those can be done conveniently on random urines. Look for hemolytic anemias or cytopenias by getting a CBC with a differential. You can look for renal function, acidosis, liver disease, muscle inflammation. Sometimes those will occur. You can check acute phase reactants as we discussed, although remember that those aren't specific for lupus and can be elevated in other causes of inflammation. Think about other diseases that could cause symptoms that might overlap with autoimmune disease, like thyroid disease, which can cause fatigue and joint achiness. Ask about thrombosis or possible antiphospholipid antibody syndrome. So in terms of lupus and mortality, actually cardiovascular disease is the major cause of death in people with longstanding lupus. And there are multiple factors that contribute to increased mortality in lupus: active lupus and infection, high disease severity at diagnosis, younger age at diagnosis, ethnicity, male gender, low socioeconomic status, poor adherence to treatment protocol, inadequate support system, and limited education. So as we discussed earlier, it is important to refer these patients early. Mortality is higher in people with lupus compared to the general population, although it's getting better. The 5-year survival rate in 1953 was 50%. Today, the survival rate is 90% because of better detection and treatment. Currently, 80 to 90% of people with lupus survive 10 years after diagnosis, but that does drop to 60% with advanced stages of organ deterioration. The leading causes of mortality are preventable with appropriate therapies. So let's move on and look at some cases. So here are 2 women with facial rashes. Which of these patients has lupus? And I'll give you a minute to kind of take a close look at both of these pictures. So it's the woman on the right. So the woman on the left, that is rosacea. And, it is an erythematous rash. It's distributed on the nose and cheeks. You can see telangiectasias. Oftentimes they'll have symptoms of flushing or have rough, sensitive skin. They can have papules or pustules like in acne, but you'll notice that it doesn't spare the nasolabial folds. It's also a little bit more central in terms of distribution. If you look at the woman on the right who has a more classic lupus malar rash, this is the butterfly rash that we refer to. It is on the nose and cheeks, but it will extend more to the sides of the face. This particular woman has more fixed erythema and maybe a little bit of induration. And you can see that it clearly spares the nasolabial folds. That's kind of a classic finding. So which of these patients has lupus? There are kind of some funny looking hands there. So in this case, the patient with lupus is the one on the left, and this is Jacquard's arthropathy. They can have swan neck deformities, which can be seen in rheumatoid arthritis, as well as you can see the Z deformity of the thumb. But the interesting thing is that with Jacquard's arthropathy, these joint deformities are reducible. And if you get an X-ray or an MRI of this patient on the left, you won't see any erosions or joint damage. The reason they get Jacquard's arthropathy is mainly due to soft tissue abnormalities. So they develop laxity of ligaments and fibrosis of the joint capsule and develop muscular imbalance. So the treatment is PT and splinting. Sometimes they have surgery. And you can also see this with rheumatic fever, but we see it with lupus and other connective tissue disease as well. The hand on the right is classic rheumatoid arthritis. You can see there's swelling at the MCP joints, probable subluxation. If you x-ray the hand on the right, you will see erosive change or joint damage. So 2 cases, which of these patients has lupus? So the one on the left is a 28-year-old woman presenting with fatigue and diffuse joint pain. She's had joint pain for 10 years, but it's much worse now. She has migraines, but no other symptoms. An exam shows no inflammation of joints, but she has multiple tender points. The woman on the right is also a 28-year-old woman who's presenting with fatigue and diffuse joint pain. Her joint pain started about 4 months ago and has become worse. She's noticed some new sores in her mouth and has had a rash with sun exposure recently. Exam shows swelling at the PIP joints of the hands. So I'll give you a minute to take in that information. So it's the woman on the right, and she has several symptoms that are suspicious for lupus: mouth sores, photosensitive rash, and joint swelling. The woman on the left has some more non-specific symptoms, and it doesn't. And so she's one of the people where I would not rush to get an ANA test, but I might think of other things to check for, like thyroid disease, or try to gather more information that might support a diagnosis of lupus, like checking a CBC or looking for other evidence of lupus, like kidney disease. So here's another case. This is a 39-year-old woman who's had swollen and stiff hand joints for 1 year, MCP and PIP joints with morning stiffness, referred to rheumatology for suspected rheumatoid arthritis. On review systems, she has photosensitivity, and on physical exam, she has patchy alopecia and inflammatory arthritis. Her labs are notable for a WBC of 3.0, which is low, and ALC of 0.8, which is also low. Serum creatinine of 0.6, her urinalysis was normal. Her ANA was positive at a 1 to 320 titer. Rheumatoid factor and CCP were negative. Smith antibody was positive. Double-strand DNA, SSA, SSB, and RMP were negative. So what is the diagnosis and why? So this woman, I would diagnose with lupus. She has a positive ANA. She has evidence of hematologic abnormality and arthritis, as well as alopecia. She has immunologic findings with the positive Smith. So I think she hits a lot of the symptoms that we would expect with lupus, as well as the laboratory findings. So I would call this lupus. Case 2. 33-year-old Black woman presents with inflammatory arthritis. She's had a positive ANA for 4 years. 1 year ago, she had pericardial and pleural effusions that resolved with prednisone. And now she's coming in with fever and cough. Her labs show a serum creatinine of 3.8, which is high, WBC 3.4. C3 was low at 61, C4 was low at 9. She has 3.1 grams of proteinuria on urine testing, and her urinalysis shows large blood. Her autoantibodies, she was ANA, double-strand DNA, SSA, SSB, and RMP positive. Her other symptoms include photosensitivity, Raynaud's, pruritic rash, and oral ulcers. So what's the diagnosis and why? So I'll give you a minute to take in all that information. So this is another case of lupus. So as you would expect, she has a positive ANA. She does have hematologic abnormalities with some mild leukopenia there. She has arthritis. She has immunologic findings, double-strand DNA, SSA, SSB, RMP. She has photosensitivity, mucosal ulcers. She has a renal disorder, serositis, and she has low complement levels. So lots of the findings that we would see with lupus. So I think this is a clear diagnosis. So case 3. So this one is one that you'll probably commonly see in primary care clinic. 47-year-old white woman comes in wanting a lupus test. She's read about lupus and is convinced she has it. Her symptoms are aches all over her body and feels tired all the time. Those have been present for a while, but worse over the past year. Has trouble sleeping and does not feel rested in AM. Past medical history is positive for migraine headaches. On physical exam, she has no swollen joints, no rashes, no oral ulcers, multiple soft tissue tender points. So should you order an ANA? What do you think? So in this patient, I would not order an ANA. I don't have, based on what I've been told, I don't have a strong clinical suspicion of disease. I think you want to acknowledge the person's symptoms though, But I think you want to acknowledge them and say, well, let's do some additional investigation. So checking some general labs, screening for hepatitis C if it's the appropriate age, or she has risk factors for hepatitis C is reasonable, checking thyroid function. But you'd want to explain that an ANA is not a good screening test for autoimmune disease or for lupus, and not predictive. So you want to look for other things. So in summary, early symptoms can be nonspecific and be easily mistaken for other illnesses or syndromes. Symptoms may be transient or prolonged and independent of one another. Consider lupus if the person you're treating presents with vague complaints from the signs and symptoms list. Also consider lupus if the person has a family history of autoimmune disease, which we didn't really discuss earlier. Do an initial screening, including CBC, BMP, LFTs, ESR, CRP, urinalysis. But as I said, save the ANA for if you're highly suspicious, and refer to a rheumatologist for assessment and diagnosis. So, as I said, this is a whirlwind. We're going to briefly talk a little bit about medications in lupus. The goal with treatment is to control active disease and prevent joint damage and organ damage, but we want to avoid toxicity of medications and target therapy to the organ systems involved. So it is a balancing act. So disease activity is what we use to determine the need for ongoing immunosuppressive therapy. And that's defined by what are the lupus manifestations they're having at that moment in time. This is in contrast to damage or organ dysfunction that's accumulated over time due to previous lupus disease activity. So there are two major types of symptoms from lupus, each treated differently. So disease activity, which is active ongoing inflammation, and damage. So this is sort of a representation of lupus. So if the forest is your body, the fire is your immune system. Here, the fire is being used for good. So that's when you have no lupus. If you have lupus activity, this is similar to the wildfires we've been seeing this summer. So the fire, the immune system is attacking the forest, the body. So treating a flare-up, where we would use water. So we want to douse the inflammation, and water is like the lupus medications. But after years of flare-ups, damage remains, and it's a problem. So it was caused by the fire, but now it doesn't respond to more water. Fortunately, if we can keep inflammation in check, you can get recovery from damage, although it can be slow and incomplete, but there's hope. So hopefully that kind of helps you to understand how treatments differ depending on whether we're trying to address disease activity and whether we're looking at damage from prior disease activity. So this may help you to understand why your patient's symptoms may not completely go away over time, and why medications that were previously helpful are not so much anymore. It may explain why some of your patients often get told your labs are fine, even though they got through explaining how horribly they feel. Whether activity or damage, they're important and real issues, and your medical team needs to address those, but they are treated differently. So I was telling Katie that this slide deck has not been updated in a while, but it's true that no drugs were FDA approved for lupus from 1958 to 2010. At the time of the slide deck, there were only 4 drugs that were FDA approved: aspirin, corticosteroids, hydroxychloroquine, and belimumab or Benlysta. Since then, we've had 2 drugs approved for lupus. So they won't be covered in this slide deck, but just so you know, there's voclosporin, which is Lupkynis, and that was FDA approved in 2021. It's a calcineurin inhibitor, and it's used for treatment of lupus nephritis in patients on background therapy. And the second drug, which was also approved in 2021, was anifrolumab. None of these are really easy to say, or Safnello, which is a class 1 interferon receptor antagonist. And it's used for moderate to severe lupus in adults on standard treatment. But we won't cover those drugs. But we use off-label drugs all the time: azathioprine, mycophenolate, cyclophosphamide, methotrexate. So steroids, I'm sure you are all familiar with. Unfortunately, we do need to use these often with lupus. They have both short and long-term effects. Short-term, they can affect appetite, sleep, and mood, especially when we're using higher doses. They may raise blood pressures and glucose short-term. Longer-term side effects include osteoporosis, accelerated CVD, and cataracts. There is a dose effect. The lower the dose, the less likely to cause problems, but infection risk is high even on lower doses. And this is just a list of a lot of the side effects that you can see with steroids, which I'm sure you're familiar with. And so I'm not going to go through all of them, but they are many. So why do we use steroids? Well, and how? Well, we typically will use them in high doses, especially in severe disease where we'll use pulse dosing of IV steroids. We then try to taper the steroid over time. There's no standard taper. The amount of the taper is unique to each patient and situation and has to be tailored. We now more rapidly institute a steroid sparing agent because we know about the long-term side effects of steroids. We rarely use more than 10 to 15 milligrams per day on a chronic basis in non-organ threatening active disease. And for active arthritis, 5 to 10 milligrams per day, although I'd argue that even the 10 is high. So antimalarials are our first line therapy in lupus. Hydroxychloroquine is the most commonly prescribed antimalarial medication. Chloroquine is available, but more toxic. Quinacrine can be used, although it's not been available in the United States for several years now. And a little bit about hydroxychloroquine. It's derived from the bark of the cinchona tree. It's analogous to quinine. It was actually first used for lupus in 1894. It raises the intracellular pH in the cells, so that inhibits acid-dependent cellular processes such as protein processing. It turns off receptor activating sites. It prevents activation of toll receptors 7 and 9. And just so you remember, the toll receptors are part of the innate immune system. So that's our first line of defense against infections, but they can become activated in lupus, leading to autoreactivity. And hydroxychloroquine has a long half-life. So why do we use hydroxychloroquine? Well, it does control skin and joint disease. Long-term use prevents major renal or CNS damage. It has a protective effect on survival in lupus, which is pretty good for a drug that's not an immune suppressant. It lowers fasting glucose in women with lupus or rheumatoid arthritis taking hydroxychloroquine. It has some mild antithrombotic properties. It has a favorable effect on lipids, and it may have a role in preventing congenital heart block, which is not an infection. This is just a table that shows the time to flare up in patients who are randomly assigned to continue taking hydroxychloroquine versus discontinuing it, or rather receiving a placebo. And you can see that when they go off the hydroxychloroquine, they're very likely to flare. So I tell my patients that hydroxychloroquine is like their lupus vitamin and they should take it all the time. It is safe in pregnancy. You don't really need to do any blood tests to monitor it, although I do routinely check kidney function because if you have renal insufficiency, you're at higher risk for toxicity. It's not immunosuppressive. It doesn't appear wound healing. Retinal toxicity, although very rare, is the biggest concern, and that risk increases with cumulative lifetime dose. Other possible side effects: GI, skin, neuromuscular, cardiomyopathy, CNS. And I just want to add too that QT prolongation is another reason that some people have been noticing that more often. It kind of came to the fore with COVID because they were using pretty high doses of hydroxychloroquine in conjunction with azathioprine to treat COVID, which is a disease that can affect the myocardium. So we were seeing problems with QT prolongation and cardiac arrhythmias. I think so. We do have a lot of medications now that can cause QT prolongation. So you'll notice now that when you order medications, sometimes your pharmacy or your medical EMR will flag you about QT prolongation. Unfortunately, there aren't really clear guidelines in terms of who should be monitored or how often you should monitor. I think the risk is mainly in people who are taking chronic medications that could cause prolonged QT. And then you're adding hydroxychloroquine to that. I think if you're in the ER and you have a patient with lupus on hydroxychloroquine who's having nausea, you shouldn't be afraid to give them a dose of Zofran, even though potentially that could cause QT prolongation as well. But again, we don't really have clear guidelines. So azathioprine or Imuran is a drug that we use off-label for lupus. It can be used in pregnancy, although the OBs aren't fond of any medicines other than prenatal drugs. It's useful in maintenance for lupus nephritis, other severe manifestations, and steroid sparing. Of course, it does have toxicity, bone marrow suppression, hypersensitivity reactions, nausea, vomiting, increased LFTs. Typically, we will check a TPMT enzyme activity before starting azathioprine to identify people who might be at higher risk for side effects because they have no enzyme activity. So mycophenolate mofetil or Cellcept is another medication we use off-label. This one is not recommended in pregnancy. It's category B. Targets lymphocytes preferentially. It's useful in lupus nephritis, lung disease, and other severe manifestations. Its toxicities are primarily GI, but can also cause leukopenia and anemia. So cyclophosphamide, not my favorite drug, but it was originally used as chemotherapy, but it does have immunosuppressive effects useful for autoimmune diseases. Typically, we use 2 IV treatment regimens, low dose every 2 weeks for several months, and higher dose monthly for 3 to 6 months. This is the most common regimen for induction therapy for lupus nephritis or CNS lupus. It can be given orally, but IV is less toxic. Typically, we do a CBC prior to dosing and then 10 to 14 days after, which is the nadir. And then we do regular UAs with microscopy because it can cause hemorrhagic cystitis. The toxicities, bone marrow suppression, nausea, vomiting, alopecia, teratogenicity, gonadal dysfunction, infections, long-term concerns, hemorrhagic cystitis, and bladder cancer, lymphoma. So methotrexate, also an off-label use. It's very effective though for arthritis and lupus. Not as effective for internal organ involvement. It's dosed as we do in RA, and I use up to 25 milligrams PO or sub-Q weekly. It's given with folic acid, 1 milligram per day to prevent side effects. The toxicities are bone marrow suppression, GI, alopecia, photosensitivity, and important in younger women, teratogenicity. So complications of immunosuppressants and cytotoxics, infection, cancers, infertility, teratogenicity. So the biologics, these are newer therapies for lupus. And a biologic is defined as a substance that's made from a living organism or its products and is used in the prevention, diagnosis, or treatment of disease in humans. Biologic drugs include antibodies, interleukins, and vaccines. And our first biologic for lupus was belimumab or Benlysta. It was FDA approved for treatment of lupus in 2011. It's a monoclonal antibody against BLyS, which is the B lymphocyte stimulator. There were 2 trials for FDA approval where they added belimumab to standard of care in active lupus, but they excluded severe lupus such as nephritis. It's given 10 milligrams per kilogram IV at 0, 2, and 4 weeks, and then every 4 weeks as an infusion. It's now also available as a subcutaneous injection that's given at a dose of 125 milligrams once weekly. It's about $2,000 per dose. In 2020, the FDA approved belimumab for treatment of lupus nephritis in adults on standard therapy. In 2022, they added approval for treatment of lupus nephritis in children 5 to 17. But we're still trying to figure out where does this play a role in our lupus armamentarium, because it is very expensive. So medication access is an issue. Hydroxychloroquine, if you get it generically, is relatively inexpensive. The generic is 60 tablets for $80 to $110 per month, typically covered by insurance. Immunosuppressants, these are common costs for mycophenolate. Again, the brand name is much more expensive than generic. Azathioprine, methotrexate, typically Sometimes we'll use parenteral methotrexate because it's often cheaper than the oral. Cyclophosphamide is usually given IV, so I don't know the cost of that. And as I said, biologics are very expensive. And I haven't priced out the newer drugs for lupus, but I suspect those are expensive as well. So other non-pharmacologic interventions, UV protection is really important in patients with lupus. So I always discuss sun protection and using sunblock. We typically avoid sulfonamide containing antibiotics, but you may have to weigh the benefits and risks. It can potentiate sun sensitivity. There's some thought that patients with lupus are at increased risk for side effects with sulfonamides. Avoidance of immunizations with live virus or any live vaccines. Smoking cessation is important. Not only is smoking pro-inflammatory, but it does alter the metabolism of hydroxychloroquine, which can make it less effective. We emphasize standard immunizations, monitoring lipids, blood pressure, bone density. Birth control is really important. Incorporating exercise or physical activity and diet as part of treatment is also important. So vaccination of immunocompromised persons. Specifically, we want to make sure they've had a pneumonia vaccine. Right now, the recommendation is Prevnar 20, influenza vaccine every year, and Shingrix is approved now for immunocompromised patients over 18. Other vaccines are specifically contraindicated in immunocompromised patients, and those are typically live vaccines. So MMR, varicella, zoster, which is the Zostavax, and FluMist. So a few more cases going back. So this is a 19-year-old woman with a new diagnosis of lupus with nephritis. She presented with anasarca and elevated blood pressure. Other findings include leukopenia, lymphopenia, Coombs-positive anemia, and thrombocytopenia. She has nephrotic range proteinuria and hematuria. Her serologies are notable for positive ANA, positive double-strand DNA, low C3 and low C4. She was diagnosed with class 4 lupus nephritis, which is diffuse proliferative glomerulonephritis. So how should her treatment plan differ from case 1, which I had forgotten, so I went and looked it up. Case 1 was a 39-year-old woman with alopecia, inflammatory arthritis, and some mild decrease in white blood cell count. And in what ways should it be similar? So I'll give you a minute because I know that's a lot of information. So case 2, this is lupus nephritis in a 19-year-old woman. So she really needs aggressive treatment in the short term to prevent damage that's irreversible to her kidneys. So the long-term goals related to lupus are to reduce her corticosteroid exposure and prevent damage. So the treatment in some ways is similar to case 1. I mean, you'd probably still give her hydroxychloroquine, but you'd want to make sure she has appropriate nephritis therapy like corticosteroids and an immunosuppressive agent with the goal to eventually taper off steroids. She also needs blood pressure control, an ACE or an ARB if she has proteinuria. And in a 19-year-old, we need to discuss contraception. So case 3, this is a 51-year-old man presenting with arthralgia for 3 years. And he came in for rheumatology evaluation. He has no other symptoms suggesting other organ system involvement. On physical exam, he has bilateral 2nd and 3rd MCP joint swelling. And this rest of his exam is unremarkable. So you do some additional labs, and he's rheumatoid factor and CCP negative. His ANA is positive and is a dual pattern, 1 to 320 speckled and 1 to 40 homogeneous. He's anti-double strand DNA positive, SSA, SSB positive, but SM and RNP negative. So what medication would you recommend for this patient? So this is also lupus. So he was started on hydroxychloroquine and his joint symptoms and swelling improved. He did have a flare of arthritis, and so he was treated with a prednisone taper starting at 20 milligrams daily. Repeat history and physical exam showed no signs or symptoms to suggest other organ system involvement. Repeat labs showed that his double-strand DNA remained positive, WBC was 4.9, absolute lymphocyte count 0.9, no anemia or thrombocytopenia. C3 and C4 were normal, UA was unremarkable, serum creatinine was 0.8. So what do you think of the prednisone dose? And would you change anything in his regimen now? So as I said, he meets criteria for SLE based on his positive ANA and double-strand DNA, as well as his other autoantibodies. He had some mild lymphopenia and arthritis, but it is relatively mild disease. So treatment with hydroxychloroquine is appropriate and was continued, and he continues to do well without recurrent flare-ups. You would not want to keep him on prednisone long-term. So in summary, lupus is a heterogeneous disease and treatment depends on the organs involved in the severity. The goal is to minimize medication toxicity, especially when considering corticosteroids. Understanding the pathogenesis of SLE is leading to development of more targeted treatment, and don't forget the Plaquenil hydroxychloroquine. So some general health maintenance and preventative care considerations in lupus. So why is it important? Well, lupus patients are at high risk for comorbidities and complications like cardiovascular disease, infections, osteoporosis, and those can be mitigated by appropriate preventative care. However, the provision of preventive care in patients with lupus is suboptimal. They've done studies showing that even though we see them regularly, we're not too good at doing some of these things. So I think enlisting the help of primary care is often what we do, and I'm grateful for your support. The proportion of SLE patients who receive recommended primary care services: influenza vaccine 57%, pneumonia vaccine 49%, cholesterol monitoring 65%, low-dose aspirin 52%. So I think we could do better. Lupus patients who are less likely to receive primary preventative services include younger patients, uninsured, individuals who do not have a PCP. So learning objectives related to health maintenance and preventative care, knowing the risk factors for premature coronary artery disease and lupus and risk modification strategies, recognize osteoporosis risk factors and its treatment considerations in women of childbearing age, identify appropriate immunization schedules for lupus patients, and understand contraindications to immunization among patients on immunosuppressive medications. So ACE inhibitors for nephritis and proteinuria. So if a patient with lupus has renal disease and has proteinuria greater than 300 milligrams per day, or a GFR less than 60 and 2 blood pressure readings, including the last reading with SVP greater than 130 or diastolic greater than 80 over 3 months, then pharmacologic therapy for hypertension should be initiated, or the current regimen should be changed or escalated unless patient refuses or contraindications are noted. If the patient with lupus has proteinuria 300 milligrams per day, they should be treated with an ACE inhibitor or ARB unless there's refusal or contraindications are noted. So teratogenic drug counseling for reproductive age women is extremely important. If a woman between 18 and 45 years of age is started on any of the following medications for lupus: chloroquine, quinacrine, methotrexate, azathioprine, leflunomide, mycophenolate mofetil, cyclophosphamide, cyclosporin, or thalidomide, and are biologic and new therapies, then a discussion with the patient about the potential teratogenic risks of therapy and about contraception should be documented prior to drug initiation, unless the patient is unable to conceive, i.e. has had a hysterectomy, oophorectomy, tubal ligation, or is postmenopausal. Although we are primarily discussing women, male fertility is an issue as well. It hasn't gotten as much attention because we typically are talking about females when we talk about lupus, but like cyclosporin can affect sperm and cause abnormalities. Methotrexate, we try to stop 3 months before patients are going to try for pregnancy because we're concerned about sperm viability and abnormalities. So it's an issue for men as well. So cardiovascular risk assessment. If a patient has lupus, then risk factors for cardiovascular disease, including the following, should be evaluated annually. smoking status, blood pressure, BMI, diabetes, and serum lipids, including total cholesterol, HDL, LDL, and triglycerides. Pneumococcal vaccination. So if a patient with lupus is on immunosuppressive therapy, then they should get an inactivated influenza vaccine annually unless patient refusal or contraindications are noted. And a pneumococcal vaccine should be administered unless patient refusal or contraindications are noted. Bone mineral density testing, treatment in steroid users, osteoporosis treatment. This one is a kind of a busy slide, so I'm going to put all the information on here all at once, even though it's a lot. So in a patient with lupus who's receiving prednisone greater than or equal to 7.5 milligrams a day for more than 3 months, they should have bone mineral density testing documented in the medical record unless they're already receiving treatment. If a patient has received prednisone at a dose of 7.5 milligrams or greater for more than 3 months, then it should be recommended that they take supplemental calcium and vitamin D, and that should be documented. If they've received prednisone at a dose of 7.5 milligrams per day for more than a month, and they have a central T-score less than or equal to -2.5, or a history of fragility fracture, then the patient should be treated with an anti-resorptive or anabolic agent unless the patient refuses or there are contraindications noted. So that was kind of a whirlwind. And so if you need more information or have questions, this is an email that you can send them to. I think we have some time now to do some questions. Thank you for bearing with me through this. I think it was like almost 100 slides. So yes, I'm gonna unshare my slide now. I hope everybody's gotten that. Just a reminder though, before I unshare the slideshow, that you will be getting a post-test survey, and that will be emailed to you, and make sure you complete that in order to get your certificate. Other resources that you can access, there are presentations, videos, interactive case studies, and CME courses at the Lupus Initiative. And that's lupusinitiative.org/CMECE. And those are great. And I just want to say thank you. It's been great having the opportunity to share this information with you today, and I look forward to your questions.
Thank you so much, Dr. Lee. That was an excellent presentation. There have been a few questions posed in the chat, so I can share those with you. I'll just take them in order here. So the first are 2 questions from one person. How specific CCP is for lupus diagnosis? And what autoantibodies test do you order when you suspect the patient has lupus?
Okay, so CCP antibody is actually a more specific test for rheumatoid arthritis. So that one, if you have a patient that's presenting with joint swelling, and you're not sure, it could be lupus arthritis, or it could be rheumatoid arthritis, then checking a rheumatoid factor and anti-CCP antibody can be helpful. Rheumatoid factor, again, is one of those tests where if it's positive and you've got the right symptoms, it helps you out. If it's negative, it doesn't mean you don't have rheumatoid arthritis. The anti-CCP usually goes along with the rheumatoid factor, but as I said, it is more specific, and that one actually can be predictive. So people can have a positive CCP antibody prior to developing rheumatoid arthritis. But if they've got the right joints and their CCP is positive, that's probably rheumatoid arthritis. If you're worried about lupus, then again, you probably want to build a case, at least in your mind, that the patient has lupus before deciding to do ANA testing, because ANA testing isn't a great screening test. So the more convinced you are in your mind, or based on the patient's presentation and their physical exam and maybe other laboratory findings that they have lupus, the more helpful the ANA testing is. And so that's why in the slideshow we say, well, if you're like, well, these symptoms are kind of non-specific, I'm not really sure, then just getting some baseline labs like the CBC or the urine tests inflammatory markers to see, oh, wait, so their symptoms are non-specific, but they've got leukopenia, and I don't know why they have that, or they have proteinuria. That would be something, but that, oh, well, I probably should go ahead and order an ANA test. And if, again, since I'm highly suspicious, I might just order an ANA panel in that case and check complements because I'm suspicious that they have lupus. If I'm still, I do the C, as I said, because the symptoms are non-specific and I'm not sure. So if I get a CBC and BMP and urine tests, I might also, as I said, check a thyroid test, because that can commonly cause a lot of symptoms that can overlap with lupus symptoms. And thyroid disease is very common in women and in the general population. And hepatitis C is kind of a stealth one. Oftentimes people aren't particularly like symptomatic in terms of hepatitis C, like they don't have obvious liver disease, but it can cause a lot of symptoms that we see with lupus, like fatigue or just not feeling well, joint achiness. So in the appropriate population, hepatitis C screening would be a good one to do as well. Does that answer? Hopefully that answers the question.
Great. Another question is, does any amount of UV radiation trigger lupus flare-ups, or is there some amount that is safe for just vitamin D sake?
I think that's a tough question, because I don't know that anybody's ever said, well, had sent out lupus patients with UV monitors to determine like what's the amount that they can tolerate. I mean, it's hard because yes, you do want to, people want to get vitamin D from the sun, but as I said, UV exposure is a very common trigger in patients with lupus. And so, typically our patients with lupus, we advise them to take supplemental vitamin D and try to avoid UV exposure, because it's very hard to control how much exposure you're getting. And I have had patients who have flared, even though they told me they sat in the shade, so, and it was only for a little bit, or they just went to the mailbox and they got sidetracked and talked to the neighbor. And yeah, and so I think you just have to be careful. And so I think it's probably better not to risk it, especially if you are somebody who has, some people have very, very pronounced photosensitivity and sensitivity to sun exposure, where I have seen pretty serious flare-ups of lupus with sun exposure. So.
Great, thank you. And there's, I think, just one last question. So maybe we can cover it very briefly here. And then we'll be sending, again, the link to the post-test and how to access your CME credit to you through email. So the last question is, could you talk more about the neuropsychiatric symptoms commonly observed? Are there any cognitive concerns?
Oh, that is not a simple question, because I think the neuropsychiatric symptoms can range from just sort of kind of brain fog, or just sort of like feeling a little off, to, seizures, or, and so it's a really broad spectrum of findings. And we do worry about cognitive complaints. And some of that, can be due to active lupus disease. Some of it, may not be so specifically disease related, other than, oftentimes patients with lupus, especially if they have inflammation ongoing, it disrupts their sleep. And that's going to alter, cognitive function. As I said, they're higher risk for cardiovascular disease and also just vascular disease in general. So, if you do get MRIs of the brain, you can see a lot of non-specific white matter changes like you would in somebody who has chronic hypertension or diabetes, and those can contribute to cognitive changes as well. Seizures and chorea and strokes, those are, meningitis type symptoms or encephalitis type symptoms. Those are probably more extreme neuropsychiatric manifestations. And so oftentimes we rely on our neuro colleagues to help us with those, because they may require more invasive investigation, like lumbar punctures and evaluating the fluid for signs of inflammation. So it's a very broad spectrum when it comes to neuropsychiatric manifestations. There are some antibodies that can be helpful in people who have the more extreme neuropsychiatric symptoms because they seem to correlate with brain inflammation, but they're not part of the regular panel. And so they're not things that I would expect non-rheumatologists to be routinely ordering. So hopefully.
Excellent. Thank you so much, Dr. Lee. This was a webinar packed with information, so we appreciate your great presentation of it and everyone's attendance and attention today. A recording of this presentation will be accessible starting early next week on NAO's website, and I've put links to the post-test and information or email addresses for more questions or to access your CME credit. So thank you all for attending. And thank you, Dr. Lee, again for your expertise.
Well, thank you all I'm excited to work with all of you. And as I said, we want to provide the best care we can for our lupus patients. So I appreciate you taking the time out of your busy schedules to be here with us today. And thanks to AHEC too, because I appreciate your support. And as I said, I teach medical students who have benefited a lot from your programs as well. So thank you.
Fabulous. Thank you all.